Hello, my name is Brittany Lamont, and I am joined here by
Mariah Hatfield
and
Danny Moss.
and we are occupational therapy doctoral students at the University of Arkansas and University of Arkansas for Medical Sciences. Since May is Mental Health Awareness Month, we are going to provide information to spread awareness on bipolar and related disorders. Bipolar 1 disorder, according to the DSM-5, is defined as a manic episode preceded or followed by hypomanic or major depressive episodes. A manic episode is defined as a period of abnormally elevated or irritable mood and an abnormal increase in energy or goal-directed activity. Symptoms of a manic episode include grandiosity or inflated self-esteem, being more talkative than usual, having racing thoughts, being easily distracted, needing less sleep than usual, and engaging in risky behaviors that could lead to negative consequences such as uncontrolled buying sprees. In order to receive a diagnosis of bipolar 1 disorder, an individual must experience 3 or more of these symptoms lasting for 1 week that are not attributed to any other substances and that impair their functional ability to complete daily activities or require hospitalization to prevent them from harming themselves or others. In addition, the symptoms experienced during a hypomanic episode are virtually the same as the symptoms experienced during a manic episode. However, they do not impair the individual's functional ability to complete daily activities and do not require hospitalization. The symptoms experienced during a major depressive episode can include feeling sad or hopeless, having a decreased interest in daily activities, insomnia, agitation, fatigue, decreased concentration, guilt, suicidal ideation, or a suicide attempt. In order to be considered a major depressive episode, an individual must experience at least 5 of these symptoms occurring over the span of 2 weeks that are not attributed to other substances and that impair their functional ability to complete daily activities. With that being said, even though hypomanic and major depressive episodes commonly occur before or after a manic episode, a diagnosis of bipolar 1 disorder only requires the experience of a manic episode. Common interventions for bipolar 1 disorder include psychotherapy, such as social rhythm therapy, to establish daily habits and routines, cognitive behavioral therapy to promote healthy, positive behaviors, and family-focused therapy to provide support from the family to encourage treatment adherence. Additionally, for medications, a gold standard for bipolar disorder is a mood stabilizer called lithium that has side effects such as headache, nausea, and dizziness. Other medications used can include an antipsychotic, such as Abilify or Seroquel, and an antidepressant, such as fluoxetine, that can be used to help manage symptoms of bipolar 1 disorder. Potential barriers to occupational performance from bipolar 1 disorder can include unpredictable mood swings, reckless behaviors, and having a decreased interest in daily activities. These symptoms can make it difficult for an individual to complete daily activities related to work, such as meeting work deadlines, social participation, and leisure activities such as sports or hobbies.
Bipolar 2 is a type of bipolar disorder that includes both depressive and hypomanic moments. Classification of bipolar 2 includes depression for a 2-week period or more, with a hypomanic episode lasting a minimum of 4 days. The main difference between bipolar 1 and bipolar 2 is the absence of a manic episode. The difference between mania and hypomania is that hypomania is usually during a shorter period of overactive behavior, usually only lasting a few days, in relation to mania, which can last a few weeks. Physical and emotional impacts of bipolar 2 include, but are not limited to, consistent elevated or irritable moods, feelings of sadness or hopelessness, compulsive behavior, irritability, restlessness or self-harm, some lack of concentration, racing thoughts or thoughts of suicide, and then excessive sleepiness or insomnia. Interventions that are often used to manage bipolar 2 symptoms include cognitive behavioral therapy, or CBT, group counseling, family therapy, psychoeducation, and psychotherapy. Mood stabilizers are often also used in conjunction. Some medications that we often see are antipsychotics, antidepressants, and SSRIs. Specifically, lithium is the gold standard. Latuda is also an excellent alternative. It's less addictive, but it can be more expensive for our clients. Some possible side effects to consider include fogginess, increased urination, headache, and shakiness. Potential barriers to everyday living include low energy and unpredictable mood swings, as well as reckless behavior. This can affect a person's ability to go to work as they may have low energy. participate in education, as they may have an inability to concentrate, get a good sleep routine, as they may have erratic sleep patterns, socialize, as they may have difficulty connecting with others and sharing what's going on and how they feel, and difficulty managing their medication or their health management schedules with their PCP.
According to the DSM-5, cyclothymic disorder occurs when someone fluctuates between hypomanic and depressive symptoms for 2 or more years. This is different from bipolar 1 and bipolar 2 disorder because the symptoms do not become episodes, which is why it is diagnosed differently. However, if the individual cannot maintain a stable mood for more than 2 months, there is a chance that they have cyclothymic disorder. Similarly to bipolar 1 and 2 disorder, someone with cyclothymia would still swing between high and low moods, and certain events would trigger overly optimistic or pessimistic responses. From a simple search on ADA, I found that during a depressive stage, an individual with cyclothymic disorder may gain weight, feel easily fatigued, and have little motivation to participate in daily activities. On the other hand, during the manic symptoms, which never fully turns into a manic episode, an individual may be more hyperactive, unable to rest, and lose weight due to high distractibility. Interventions are similar to bipolar 1 and 2 diagnosis, which requires psychotherapy, which can be CBT or group therapy that is family focused. However, medications are not always necessary for this diagnosis, if therapy is effective. Mood stabilizers can be prescribed if symptoms are severe enough and therapy alone is not effective. It is important to note that mood stabilizers can cause slurred speech, itching, rash, tremors, and irregular heartbeat. It is important to talk to your doctor about these possible side effects. Furthermore, occupational therapists can help people manage their symptoms by helping implement healthy routines and develop coping mechanisms for events that could cause those overly happy, sad responses that impacts daily life. The main barriers I found are somewhat dependent on the hypomanic versus depressive symptoms, but often have the same result. For example, high distractibility and lack of concentration or motivation could affect how someone performs in work or school. Both sets of symptoms also cause sleep disruptions, which could affect attention, concentration, and participation in daily occupations. Lastly, familial or social relationships can be affected by sudden irritability or reactions to stressors like changing jobs, moving, or breaking up. And intimate relationships can further be affected by sudden changes in sexual drive and even self-esteem. Here is an image of the brain activity that occurs during bipolar and related disorders. The left shows inactivity while in a depressed state, while the right shows the areas that are active during a manic episode. As you can see, these images are highly contrasted with the one you see in the middle, which shows normal brain activity.
In order to further our understanding of bipolar disorder, we met with a personal friend of ours that was diagnosed with bipolar disorder as a teenager. She was hospitalized at 17 and given a formal diagnosis of bipolar 2 as an adult. She stated that some barriers for her included the inability to trust her own emotions, not being able to share her diagnosis or struggles with others without feeling like she's coming out or having to tell a big secret. She constantly feels like she's tied to her medication for regulation, and she deals with suicidal ideations frequently and fears that this will put her back into the hospital. She wishes that others knew that when you're depressed or hypomanic, with bipolar 2 specifically, sometimes you wish you could just feel anything. For her, the world feels like a cloud of nothingness that she could just float through, and she often stated that she missed that manic moment. She stated that she's scared of the next fall back into depression, and she feels on the edge consistently of when it will happen next. She also stated that there's not just one type of bipolar disorder, and it looks different person to person. She also stated that she wished others knew that mania is not just people thinking that they're God or that they can fly or in a euphoric moment. A lot of times it's their version of happiness. And then she also stated that depression's not just a phase, and we do not need people to tell us that it will get better. Thank you so much for listening. We hope that we are able to raise awareness on bipolar and related disorders. If you have any further questions, we would encourage you to reach out to the National Alliance on Mental Illness as listed below or your local mental health provider.